Welcome to Health Talk. Today we have with us Dr. Dipa Patel, who is a board-certified radiologist with special certification in breast imaging. She's Director of Breast Imaging Specialists in Los Gatos, California. Our topic today is breast imaging, and it's a big topic because breast cancer now affects many women, 1 in 9 or 1 in 7, depending on the statistics. So tell us, what is it special now? What's new in breast imaging?
Well, I would say that the latest technology that has been talked about in breast imaging, which is really about the biggest advance in imaging of probably the century, is 3D mammography. So its official name is tomosynthesis. So it's 3D tomosynthesis, and tomosynthesis has been used for other imaging techniques such as kidneys in the past, CT scans, or computed tomography. So now they've actually developed a technique for the breast. And so the tomography allows you to slice through the breast tissue. And the reason it's actually an amazing new tool is because one of the main problems with mammography in the past has been that women with dense tissue or moderately dense tissue have had trouble seeing lesions in the breast because a lot of it gets obscured when you only take 2 images. Essentially, you're averaging the density, the dense part of the breast tissue from one end to the other when you take 2 images. So you're really overlapping a lot of tissue. When you overlap that tissue, you can actually hide a smaller breast cancer, sometimes a bigger breast cancer. And having this new technology allows you to really slice through the breast tissue, see what's at each incremental level with 1 millimeter slices. And then the amazing part of it is that you're not using the dosages that you do for the other tomography because you're using essentially breast dosages. So you get the equivalent radiation for a regular mammogram. And yet you get all the imaging advances of really, the tomography, which is a very impressive achievement.
Now, Evelyn, who's our guest interviewer, has been active at University of Iowa. She's a master's of public health there, and I'm sure you've been involved in breast screening there or breast screening issues. What would your questions be for representing Iowa and the rest of the women that you've ever seen for Dr. Patel?
Well, thank you for being here. I have a lot of questions, actually. I think it would be great if you could start off and just tell us, what the screening guidelines are right now and why, just for the general population.
Sure. The screening guidelines right now is that you do annual mammography starting at age 40.
Okay.
So pretty much the beginning for most people with no family history is 40, and the endpoint really is an endpoint of your choosing. We pretty much say that as long as the patient is healthy, able to function, get along, get about, and they have, a good, level of longevity, you continue offering them screening mammography once a year. So there is no end limit. Okay. And the way breast cancer statistics works, after menopause, the incremental rise in breast cancer diagnosis is actually about a 45-degree angle. So before, it's more of a 20 to 30-degree angle. After menopause, it actually goes up. So even though you don't really have the estrogens that are really feeding into some of the breast cancers that are estrogen dependent, and so technically some of the more aggressive tumors happen to be estrogen dependent, after menopause, even if you're not on hormones, there is a higher incidence of breast cancer that goes up pretty much at a 45-degree angle. So the older you get, the more likely you are to develop breast cancer. But the idea is that it's not as aggressive most of the times. And so if you're good about your screening intervals, even a yearly interval, even if your incidence increases significantly, you're going to be able to detect it and treat it very quickly.
Okay.
Now we have on our other side Veena, who's a bachelor's of engineering from Berkeley. Now, are you concerned about the radiation or anything you want to ask? What questions might you ask Dr. Patel for our home audience?
Okay, so you said there is a mammography and 3D mammography, and I want to ask, what else is possible to screen the breast cancer in radiology department?
There are several methods to screen. So The basic screening is a mammogram. Now, we do offer mammography for not only just women who are at least 40 and above, but we offer it for those who have a strong family history of breast cancer or any family history of breast cancer. So there are women who know that they have BRCA positive markers. So if they have the BRCA gene, they are supposed to increase their age or lower their age of starting mammography. And if they have a known family history of breast cancer, we usually start at 35 or 10 years earlier than the age of diagnosis of the relative with breast cancer. So there are some women who've had it in their 30s and 40s. We try to start about a decade earlier. My usual threshold in the 20s is at least 27, and then you start the annual mammograms at that point. If they're
So these are people who have a family history or who have BRCA gene positive testing.
Exactly.
Then you would start a decade earlier, so that would be like the earliest you would say is 27.
Right, and there are some women who their physician has said, well, you know, somebody diagnosed in the 30s, your mother had breast cancer when she was 32, I want you to start a decade early. So for those women, what we do is we get like a single view. So we try not to get the full spectrum of 2 views for each breast, total of 4 views. We at least get what's called an MLO view, so the one that pretty much gets most of your breast tissue, and we hope that, you know, on those 2 views we at least rule out the big things. And then when they get older, at least 27 or more, you can add the second view in too.
Now, it used to be said that a chest x-ray is equivalent to taking a flight from California to New York.
Right.
What is the level of radiation for a normal mammogram?
You know, it's very low. It's considered pretty much background radiation. So the levels for mammography are very low. So I know women talk about, you know, being very deathly afraid of getting additional radiation, but really for mammography, you're penetrating only through soft tissue as opposed to bone. So when you're actually penetrating through bone, so for a chest x-ray or the solid organs, you're getting an x-ray of the belly, the head, those are all much higher dosages because you have to penetrate through structures that are inherently more dense and requires more radiation for you to see through. But soft tissue, which is what the breast is, there's no bones in there, it's very low radiation. So it's essentially the equivalent of background radiation.
So when you say background radiation, that's the amount of radiation we would be experiencing as we're walking on Earth.
Yes.
Like just UVA radiation that we would just get.
Right. Right.
The other concerns people have are if, let's say, they have screening mammography starting at age 40, what about long-term cumulative radiation?
The long-term cumulative dosages, and now they're going to change because, you know, we're getting better and better technique. The FDA limits how much radiation exposure you can get from a mammogram. So usually you have a physicist who comes in and does testing, so that's a requirement usually every year. You get an inspection from the state, and you have to abide by certain guidelines. So there's definitely a limit to how much you can go. When you look at the lifetime risk of radiation exposure, we believe, and this is just what the papers say right now, that we induce 1 breast cancer per million over a lifetime risk. So if you look at the 1 breast cancer induced over a lifetime, that's much lower than 1 in 8 of what you're going to detect in a lifetime risk of breast cancer. So you're saving a lot more women than you're inducing the 1.
That's good for the home audience to hear because many people are afraid of radiation. What other questions? You had some questions before we started the show.
Yeah, so let's say like some people are poor but then they still want to get some screenings. Like, can they just go to your center, or like can they get some free mammogram, or what is the options for them?
Usually if a patient wants a mammogram, they can't self-refer for a mammogram. So we do get phone calls like that, that they don't have any insurance, they need to come in for a mammogram, they know at least they need to do that much. But we can't really do a mammogram because it is radiation involved. You need a doctor to at least write a prescription. And it's not really because of the radiation, it's really because of the results. So you need to have a physician of record who will write that order for you because if we find anything, we need to have a doctor who's involved in your care. So if you just call our center or call any center, they really can't just offer you a mammogram. You need to have a physician of record who you see, who we can report back to, who can contact you, and pretty much coordinate your care if we find anything, because there are times we're going to find things. So we can't just have a patient, you know, singly refer themselves and then pretty much be lost to follow-up. There's nobody responsible for you.
But if, let's say you are at the home audience and you're worried, or you're worried about your loved ones or your elderly grandmother or mother, and they're concerned about getting free screening. Periodically there are screening fairs for breast cancer that are held by every state and city. And in addition, if they want to type in just free mammogram on Google, they will find like Planned Parenthood. For California, our area would be Valley Medical Center, where they would then go see a nurse practitioner who would then connect them to a doctor who would then send them for a mammogram. So that they would have a physician of record, but they could then get into the medical system so that they would not get maybe a bad result and be left holding with a sheet of paper and be very upset with the results. So there is availability, and you can also go on the Susan G. Komen website and type in cancer screening and breast cancer screening, breast cancer mammograms, and there's a real contact person, there's email. So there's ways for people in the home audience, if they want to find a way to be in the system to find out about breast cancer screening, it's possible.
So I have a question. I've recently heard a lot of buzz about the different types of breast tissue. So what I understand is there's, I guess, regular breast tissue, and then there's dense and very dense. And I guess you brought this up at the beginning, but could you explain that a little bit more to our home audience and just explain why, if you do have this type of tissue, you might need extra testing?
Sure. So every woman has either a genetic predisposition to certain types of breast or certain types of breast tissue based on their genetics alone, or there's a variable factor that, you know, you will just probably have a certain type of density. And we would know that not by a physical exam, but really by doing your first mammogram. So there are times when your breast density increases, and those are the times when you're breastfeeding or pregnant, and so normally you have development of breast tissue, and so your density increases. Now, there are some women after they hit menopause that when the estrogen levels drop, they're not on hormone replacement or other medications that act like hormones, that their density may drop. We only see that about 10 to 15% of the time overall for most women. So most of the time, women have a density level that is stable throughout their lifetime. Part of it is genetics in that Asian women, many of the Japanese and Chinese women, they have some of the densest breast tissue. So it's just a genetic variant that you know that most likely I will have 100 women, and I'd say 99 out of those 100 women, if they're Asian, I can tell you they will have more than 50% density, usually on the 80 to 90% level. And then the other women are a little bit more variable. If you're heavier, the idea is not that you have more dense tissue, actually you have less dense tissue, because fatty tissue tends to look black on an x-ray, so your density actually decreases the more weight you gain. So, and then the women who are more athletic, they tend to have denser tissue because the amount of fat in their system is pretty low. So I start talking about the fat-free zone, so the women who are like very athletic, you know that they exercise on the very thin side, they will most likely, when you take a mammogram, have the denser tissue. Yeah, so there is some level of variability. Most people fall in the in-between category. 50% of women, 40 to 50% of women have 50% of their breast tissue or more that is dense. So about half the women walking around, statistically, 2 of us have dense tissue. 2 of us are probably under 50%.
And so then you would do a normal mammogram and then suggest to have a different test.
Right. So California passed a breast density law, which is informing patients. So I think about 2004, we just had to start informing patients about the results of their mammogram. So every woman who's gotten a mammogram is used to getting a letter in the mail saying that your results are normal or not normal. But the second part actually started this April. So the law got passed last September, but it went into effect April 1st of this year. So now we have to literally inform every woman who has dense breast tissue, which is defined as 50% or more, that they have dense tissue. And in the past, the problem was that if we didn't inform the women and we just put it on their reports, the doctor had the choice of letting the patient know you have dense tissue or not. But what was happening was some of the women with the denser tissue, they got diagnosed late with breast cancer. And, you know, they became a little bit more aware of the density. When they read more about it, they realized that had they been told that they had dense breast tissue, especially if they knew they had a family history, they had other concerns, that they would have opted to do more screening. And that more screening was never offered to them. And so that's what really started this movement to inform women so that they could take care of themselves and know what they're dealing with. So some women are very, very proactive. Some women don't care. They're, you know, too scared. They don't want to know. But, you know, now we inform people. So the idea is that if you're 50% dense or more, the few types of screening that we have are either offering ultrasound, offering MRI, or offering a nuclear medicine study. So those are the three types. Now, the fourth type, which just starts off with a basic mammogram, you can have the regular mammogram, which we now call 2D. That's the regular type of mammogram, or 3D. So there are some women now who do come to me because I pretty much have the only center in the South Bay that has 3D mammography. And so if their physician knows that they have dense tissue, they pretty much say, well, if they end up getting nothing but a mammogram, because some women don't want to go on to the next level, a lot of women do, but if they want to limit what they're doing and they just want at least one good study, they say, well, why don't you come for the 3D mammogram? Because at the very least, you'll get that slicing through the dense tissue. And I've had a few doctors who have known that their patients had 50% or more, and they've sent them to me, even just after they've had a normal mammogram, like a month before. And I found, you know, breast cancers that are about 1 inch or more. And just on the 3D alone. So, I mean, it definitely makes a big difference. Obviously made a difference for the patient because they had a normal mammogram. If it's already 1 inch this year, I couldn't imagine if they waited another year. So those things are available. Now, there are easier levels of screening than there are more difficult levels of screening. And I just call them more difficult because, one, most people are not going to want to get a radionuclide injected into their arm. You know, so that's a nuclear medicine study. And the cost is a little higher too, obviously. And it takes a lot of time. So once you inject, you have to wait several hours. Then you actually take the uptake study, which is another, you know, 45 minutes to an hour. It's a very time-consuming process. So that's not a very practical approach, although that is one approach. And gamma imaging is also coming into it. So there's, you know, less time involved. But again, radionuclide, time, and cost. The second thing is MRI. So people have heard of MRIs, but there are some people who cannot tolerate MRIs because they have metal in them. So metal is a contraindication. There are breast biopsy clips that a lot of women have. Most of those, I'd just say all of them right now at this point, are made so that they are not a contraindication to MRI. But if they say worked in a factory, they know they've had shrapnel, they know they have you know, clips from other surgeries or a hip replacement, knee replacement, they cannot have it. Then there are a lot of women who are claustrophobic. They won't be able to tolerate sitting in there with knocking noises for an hour to get the MRI. And again, you get the injection. So, you know, for a lot of women, they don't want to go through injections. They don't want to go through an hour-long or more process to get a preventive screening. So for practicality purposes, ultrasound is really the most practical. And it's pretty much like getting a baby ultrasound. Most people know what that's about, but you do it to the breast. And it's a very quick procedure. Now, it's not offered at every center, partly because there is labor involved. And so not every facility has a breast ultrasound program where they do the whole breast. They will do focal areas because if there's a problem on the mammogram or a lump you feel, they will go ultrasound that one area, but they won't do the whole breast. So I would say I'm one of the few places that offers the whole breast. There are 3D machines now that do the whole breast. And there are several different companies that do 3D. So one is a company that does 3D reconstruction from someone who actually does an ultrasound of the breast, but it's a smaller probe. You pretty much scan the whole breast, they reconstruct it. It's a little bit operator dependent because you need the person to manually go over the area. Then there's a second type of 3D machine, which I do have, and it's called a SomaView. And basically their plate, instead of being the smaller ones that you do a wand over, it's literally the size a little bit bigger than my iPad, fits on the breast and literally covers the entire projection of the breast and takes an image with the same transducer, except the transducer is no longer this big, it's this big. It covers your entire breast. So objectively, you have your entire breast covered. Now that has a different cost because some insurances cover it, some insurances don't. Right now, I would say 80% of the insurers are covering the 3D ultrasound, about 20% are not. The good thing about having the objectivity is that, and I'll just go into a little bit of the operator dependency, that if you have operator dependency of the radiologist or the technologist, that changes the variable of detection.
Sure.
So what ends up happening is that there are a lot of people who are not trained in breast imaging, but they will do breast imaging because they're general radiologists. So some radiologists are used to doing ultrasound, some are not. A lot of times the technologists will do the ultrasound, and just from my experience, not to disparage anyone, but I've often caught things that the technologist had missed. So the idea would be that if you're used to it, you're the radiologist and you're going to go in and check again, that's one level. But if you're only relying on the technologist, then you have another variable of, do you trust that they know what you're looking for when you go in versus you knowing what you're going in to look for when you are looking. So there are all kinds of variables of the experience of either the technologist or the radiologist that you get away from when you have that whole breast image, because then those are standard images. You scroll through the images one slice at a time, but most people should be able to at least recognize the static images. Even if you cannot physically, you know, cover every last inch, when you have the whole plate giving you an entire image of the breast in front of you, it's a little bit easier to be more objective.
I have a question. Breast implants are on the rise, and many women have breast implants either because of mastectomy reasons, post-mastectomy, or cosmetic. How are you as a radiologist able to image for breast cancer in patients like that?
So it's a little bit more challenging because there are different types of breast implants. So there's silicone implants, there are saline implants, and now they have all these variations of like jelly implants. So the density changes a little bit when you take a picture on the mammogram. So the silicone is usually a little bit more dense. Now with majority of digital mammography, whether you have saline or silicone, the density, the way it's manipulated, just makes it harder to see through entirely. So the regular mammograms, when you get a regular mammogram, has a hard time seeing because, again, it's only objectively 2 pictures. And the part that will have the silicone or the saline or the gummy will just be difficult to see. So you're really limiting your visualization in a plane with those. It's much better done with a 3D, or what some women opt to do is if they have breast implants and they know they have dense tissue, they will opt to get an ultrasound on top of their mammogram.
So if you have a breast implant, one would then tell the radiologist so that they would know ahead of time what type?
Well, we'll know when we take a picture. But we do need for them to tell us because we have to take extra views. So what happens is when we know that we're dealing with a patient with implants, and that becomes your standard question, do you have implants or not implants? And you're booked for the right study. So when you take the exam, you do what are called pinched back views. So you actually get a view where the implant is in place. So you actually look at the implant and get the most amount of breast tissue you can get onto the film. And then you get what are called displaced views. So you push the implant literally out of the way and you take a picture of the tissue in front of the breast implants.
Is this painful?
No, I mean, they're pinched back, so, you know, if you're normally massaging yourself, you're doing all kinds of things to your implants, so it's okay.
Okay, long live all these implants and the new technology. So we have 3 minutes remaining. I'm sure our home audience wants to know a few things, and I know you have some images on your iPad, and those are tell us about those images.
Well, I have some images that really show the differences that the 3D mammograms make in detection of breast cancer. I also have images on an ultrasound, what the equivalent image is when we do find something on the mammogram. So I have some images that show that cancers are found in very dense tissue. I actually have images that show cancers are found even in very little dense tissue. Somebody who had 30% density had their 1.3 centimeter breast cancer just positioned just so that it was hidden, would not have been caught on the regular mammogram. So I have those images just to show what the images look like, because the audience might be interested in just seeing what the images look like. And then I also have some images that really just talk about the MRI and how some of the tomosynthesis that we're doing now, the 3D mammography, can alleviate the need for the breast MRI.
So the take-home message for our home audience is that what would you want them to take home from our show and our presentation? What would they, well, 3 points?
Basically, get your mammography done, get your screening mammogram done. There are a lot of new technologies now involved that can pretty much pick up breast cancer at very early stages.
And once a year?
Once a year. And given that you have all these great screening techniques now, most of the breast cancers can be found, hopefully at stage 1, based on their level of density if they go through their full screening. And that really means that if you do get breast cancer, your survival rates are in the 95% range. So really, if you get the proper level of screening between the mammogram and the ultrasound, I would say there's no reason to fear breast cancer.
So thank you to everybody in our home audience for joining us for Health Talk. And we're really excited that Dr. Patel decided to join us, because this is obviously a very important public health topic, and breast cancer is rising. And for example, Marin County has the highest incidence in America, and that's our neighboring county up north. And it is something that every woman should consider having mammography once a year, and not to forget, because everyone leads very busy lives. And after menopause, the rate of breast cancer, as you say, goes at a 45-degree angle. So that means there's actually a larger incidence, and that people should not say, okay, I'm fine, I'm in the clear, and that we should just also be vigilant. And for all those who are concerned that they do not have insurance that covers this, there's also free screening. Go on Google or any search engine in your local city. Planned Parenthood has it, all the county hospitals have it, and all the public health facilities in every major city will tell you about the free screening and the free mammograms. Thank you very much. If you like this show, join us on YouTube, or please make a donation to KSAR TV, or do both. Thank you again.